Messing around with this green screen.
Okay. Go ahead.
Is that me? Are you, or is it?
You can go ahead, Clay.
Oh, okay. Bonjour, my relatives. Good afternoon. My name is Clayton. Everybody calls me Clay. I'm here to introduce one of our guest speakers, Dr. Holly. Um, they asked me to do the traditional opening, but I'm just going to do this traditional opening in this in this language. I just want to welcome everyone in for attending. I just want to say miigwech to everyone. I'm happy to be here. Happy that you're all here. And so we'll just take a moment or two, and if you have your sema, you have your smudge, we can start with a traditional virtual opening. That's the first time I've said that. So, anyways, I say miigwech to you all. So take a moment or two or three, and we just say, let's begin. So I always like to take a deep breath, just breathe, and just acknowledge, give thanks to our first mother of all mothers, our mother, the earth. Again, we come together as the people. We offer our prayers. Again, we pray to her. We pray for her. We give thanks for everything she provides for us, the people. We say thank you to her and all the medicine she provides for us to sustain life, to have a good life. We say thank you to our first mother of all mothers, our mother, the earth. So our minds, our hearts can be one with this. I say miigwech. I say all my relations. I say miigwech to Father Sky. Again, I offer my sema. I hold my sema and I say thank you to Father Sky. Again, I partition. I ask the spirits of my ancestors, your ancestors, those good ones, to be with you wherever you may be, to guide us all physically, mentally, spiritually, emotionally. I give thanks to them. I give thanks to Father Sky, that spirit world, that spirit realm. I thank you for everything you do for us, to our grandmothers, our grandfathers, our ancestors. Again, I say miigwech to you for always being with us, protecting us in these difficult, challenging times, physically, mentally, spiritually, emotionally. I say miigwech to you. I love you. I say miigwech, all my relations. I give thanks to the sun again for giving that appearance of rising in that beautiful doorway, that eastern doorway. I say thank you for this new day, this new beginning. I say thank you for bringing the warmth, for bringing the light, for making the medicines grow for us. I thank you, Grandfather Sun, for this new day, this new beginning. If I've done anything in the past, I have this moment, this day to make it right. And I thank you for this moment. I thank you for this day. I thank you for everything you do for us. Grandfather Sun, I thank you. So our minds, our hearts can be one with this. I say thank you. I give thanks to our grandmother of all grandmothers, Nukumis. As my granddaughter sleeps, as our children sleep, as our partners sleep, as we sleep, you do this for us. This sacred thing, you put the waters, the rivers, the lakes, the oceans into order for us. We acknowledge this. We come together as the people to acknowledge this and many other things you do for us, Nukumis. Again, I pray to you, I pray for you in gratitude for this you do for us as we sleep. For water is life. We acknowledge this. So many of us have forgotten this. But at this moment, in this day, we acknowledge this. We humble our hearts and we say, thank you, Nukumis. We love you, Nukumis. Grandmother of all grandmothers, Grandma Moon. We love you. We say thank you. Again, I pray to you. I pray for you in gratitude. I say thank you. So our minds, our hearts, and can be one with this. I say miigwech to you, Nukumis. All my relations. I offer my sema and gratitude to the great mystery, to our Creator. Creator, I ask you to have pity on me, for I am pitiful. I forget so often that I am a Anishinaabe before I am anything else, but at this moment I thank you for this, for making me a Anishinaabe, a human being. I pray to you, I say thank you, Creator, for I stand here and offer my sema, for there is nothing beyond you, Creator. I thank you for this, for holding this, helping me. I ask you to have pity on me. I say thank you, Creator, for making me, for giving us life, the sacred gift called life. I offer my sema in gratitude. We come together as the people and offer our prayers. We offer our prayers for each other and our relatives. And we come together in gratitude for this beautiful gift you have given us called life. All my relations, miigwech, miigwech, miigwech. I say thank you again for allowing me to say that very simple prayer that I try to live by every day of my life. So with that, I just want to say miigwech and then start us off in a good way. And again, miigwech to our friend, our guest speaker here. I say thank you, all my relations. And I think Suzanne would like to say something before. So miigwech.
Miigwech, thank you, Clay, for opening us up spiritually and inviting spirit into our circle here today. My name is Suzanne Stewart, and I'm the director of the Waakabanez Bryce Institute for Indigenous Health and the nominated principal applicant and person who's together with everyone else on the Ontario NEIHR team, leading the Ontario NEIHR, which is focused on Indigenous knowledges and Indigenous mental health. It's a great pleasure to have Dr. Holly Graham here today to do our monthly Ontario NEIHR webinar. And she has graciously offered to come today and share her knowledge and experience on integrating somatic-based therapies and partners for outcome or for change outcome management system into clinical practice. Dr. Holly Graham is an assistant professor at the College of Nursing and a psychologist in the province of Saskatchewan. I first met Holly, I'm not really sure, I think it was around 10 years ago at an international conference in Hawaiian territory. And there were lots of awesome Indigenous people there from across Canada that I got a chance to meet. Actually, that's not where I first met Holly. I first met Holly probably a year before that at the University of Saskatchewan. And I got to know her better at that conference. And here I am getting to know her even more through the Ontario NEIHR. So I'll let Dr. Graham introduce herself in a little bit more detail. And I'm very grateful that you came, Dr. Graham, and Elder Knowledge Keeper Clay Shirt for being here. And thank you also to Roy Strebel for technical assistance, the NEIHR coordinator. So I will stop talking and pass it off to Dr. Graham. Miigwech. And to all of the participants who are here, please type your questions or comments into the chat. And in the last 15 minutes, 10 to 15 minutes of the session, I'll be reading them out to Dr. Graham to answer. So miigwech.
Miigwech. Thank you so much, Suzanne, for that introduction. And thank you, Clay, for that wonderful prayer and opening and beginning in a spiritual way. And it's so grounding. And I appreciate being able to do that when we gather and when we come to share information and to share some of our own stories. So that's really what I'm going to talk about is, I guess, some of my experiences last 14 years, what I have found very helpful working with Indigenous peoples and specifically First Nations and Métis when we're looking at trauma with a real focus on the relationship. You know, how do we in a Western clinical setting create these relationships that can sustain and support, you know, our relatives as they work through trauma. And I'm going to share a little bit about myself and how I've come to this path. But I just wanted to start with just a land acknowledgement that in Canada, we live, we learn, we play, and we work on traditional Indigenous territories. And I wanted to pay our respects to the First Nations, Métis, and Inuit ancestors, and to affirm our commitment to respectful relationships with one another and with this land as well. I've had many teachers, Indigenous and non-Indigenous, and mentors, and I just want to acknowledge that I feel I've been truly blessed to have had this opportunity to talk and visit and get to know different perspectives about my own Cree culture. I just want to acknowledge Gitayak Austin Tatusis, as I've been spending a fair amount of time with him for the past 5 years. And he's been so patiently, because I'm not fluent in Cree, which makes a big difference for learning a lot of the deeper meanings in our language, has been teaching me more intimately about Wakotewin and whatnot, about how we're all interconnected and interrelated. So I have many teachers and many mentors, but I just wanted to start with that. A little bit about me. This is my great grandfather, and great-grandmother on the top. And furthest to the right, that's my grandfather, kind of the oldest boy on the right. And so that's just some pictures. This picture was actually in the museum in Winnipeg and was taken by a relative and then sent to me and whatnot. And then when I look at the middle, that was my grandma Pichal. And I have very fond memories of her growing up. And she's in the middle there holding the baby in the center. And I think that's my Aunt Catherine and whatnot. This is a picture of my mother, myself, and my daughter. And my mother is still alive, and she attended the residential schools all of her life, and also took her training as a certified nursing assistant in a convent as well. And she'll turn 81 March 14th. So we're just getting ready to celebrate her birthday this weekend. I really wanted to talk today about really what is a healthy nervous system and a little bit about the impact of trauma. I'm not going to focus so much on trauma, but really looking at what happens when we're not able to deal with it, and really those negative beliefs that we have about ourselves, how it becomes internalized in those earlier events. I look at coping versus healing, and then share what I have found in my practice of 14 years with EMDR, and then using the PCOMS as well for that same amount of time. Before I start talking about it, I do want to say that I did my own trauma work 20 years ago with EMDR, and that actually is in fact the reason that I began the journey to become a registered doctoral psychologist. I also want to say that I was very fortunate, even though my mother and all her family was in the residential school and attended, that I was fortunate to be brought up in ceremony and Sundance. My Cree name is Ukamau Thicksquo. And I was given that when I was about 9 years old by one of the blind elders at the Sundance. So I've been very fortunate. I guess my path has been interconnected with both my traditional and also Western ways of knowing. We can't help but say that when we've been educated and have a PhD, I've definitely been influenced by Western medicine thinking and ideology. But what I want to kind of share today, and that's what I'm going to be focusing on, but I do want you to know that I have totally embraced my culture and have been involved in ceremony since I was about 9 and to the date. And I'm in my 50s, so it's still a ways to go, lots to learn. So I just want to start off with a healthy central nervous system. And I like diagrams because it just shows a gentle wave. So it's just that gentle wave. We wouldn't want to be flat because that would just be completely flat, and you wouldn't be experiencing kind of the ups and downs and the spectrum of emotions. So when my central nervous system is balanced, basically I'm in a good place for learning, and I'm in a good place to realize that I have choices and options. And I also know that I can reach out if I need assistance and whatnot. So I'm basically able to be present, and that is really key. And I'm available for learning. And, you know, if I'm in school, it's a good place to be. When we look at trauma in itself, and there's so many different definitions of trauma, I'm just going to say briefly, it's any experience that overwhelms a person's capacity to cope. So if you think of a little 18-month-old little boy who falls for the first time and scrapes his knee, and it's the first time he sees blood, that is very traumatic, can be very traumatic for him, particularly depending on how the caregiver responds to that. So it's all relative when we look at trauma and we look at capacity to cope. Ideally, in that scenario with that little person, is the person who's first there, but just say, what happened? Let me help you. And would take care of the wound, clean up, put a Band-Aid, and just say, you know, how are you doing? Kind of like, I'm so sorry you scratched your knee. That must have been scary. Let's go fix it up. And have that nurturing, and to let that little person know that they're going to be okay, but more importantly, that they have someone who's going to help them through this experience. But what I'm talking about more today is what happens when we don't have those people there to navigate, those people to help us through those really tough times and whatnot. Some definitions more of trauma is just really that complete loss of control, you know, just having no power, and we don't have the capacity to respond. And so really it's about loss of connection to ourselves and to everyone around us. And when you think about Okoto and the concept, it's about we're all interconnected and interrelated. And when we don't understand that, and we're not able to connect to that in a meaningful way spiritually, And in every way, that affects our wellness and whatnot. So this loss of connection from Western perspective, we could call this disassociation. You know, there's other terms we could use. That's a more extreme form when people have out-of-body experiences. But this loss of connection is exhibited in numerous ways. I do want to talk about the adverse childhood experiences because the prevalence of trauma, it's ubiquitous. It's everywhere in our society. As Indigenous peoples, we don't have this market cornered, even though we have experienced undoubtedly far more trauma. But when we look at the adverse childhood experiences, this is the largest longitudinal study that was done in the mid-90s with 17,000 primarily white middle upper class individuals. And what they found is actually the greater experiences of adverse childhood experiences that a person has, it's dose response type thing, dose relationship, then the greater number of social emotional disease, disability, and early death that would happen. So there's that correlation of more of this adversity in your childhood with these 10 areas, then it actually does have the capacity, and it actually does impact. So this is with individuals who are white, middle class, so primarily what we would say have far more privilege than most of our relatives and many immigrants. So when you look at these scenarios of these 10 situations, what they found with this group is that physical abuse was quite common. 28% had experienced it. So was sexual abuse, approximately 1 in 5. When you looked at more than 2, 40% had experienced 2 or more adverse childhood experiences, and about 12.5% had experienced 4 or more. And as I mentioned, there's that dose response relationship with the many health problems, both physical, mental, emotional, and spiritual. So what does it mean? So there's this link between childhood trauma and chronic diseases. And we look at the statistics for Indigenous peoples, you look at cardiovascular disease or diabetes, our rates are 2 to 4 times higher. And if you look at mental health, particularly suicide, it's 5 to 6 and up to 11 times higher when you look at individuals who are Inuit. So this has implications when we look at trauma of, first of all, acknowledging it and healing it and preventing it. So whenever we're talking about mental health, it's important we know our history and we know what contributes to the current issues that we see in our practice, but more and more as upstream thinking is how do we prevent it? The magic number is 4. And so those people who are 4 now in my practice, I have to say all First Nations individuals that I've treated, and myself included, are well over a 4. So that's important to know, is that 4. I do want to talk about healing-centered engagement. And healing-centered engagement is really looking at this diagram. And so often in Western science, Western perspectives, when we look at psychology and mental health, we focus on helping this caveman run better, sleep better, cope better, and whatnot. But eventually this caveman is not going to be able to run because this saber-toothed tiger is bigger and larger and is everywhere. And this saber-toothed tiger is really our institutional policies that have racist policies and perpetuate racist policies that just continue to go on and on and on. So healing-centered engagement is really acknowledging culture and identity at the forefront, that is absolutely foundationally important, but it also acknowledges the importance of advocacy, of addressing the systemic challenges and barriers that people are facing that are causing those inequalities and inequities in health. So healing-centered engagement is taking one step, and it's working with the individual, but it's also looking at the systems that are creating the oppression and the that contribute to the disparities. We've heard many times about the fight-flight response, and I think most people are very familiar with this, and this is something that I teach all my clients and little people when I work with little people too. So it's really important to know that when we are stressed, that and this could be on a continuum from minor to major, so smaller incidents to larger, but the body basically is designed to defend itself, to survive. And that's the whole goal, is what it wants to do, is I want to survive. Whatever comes in my way, I want to survive. So if it anticipates danger, it'll create this system where all the blood is pumped to our large muscles so we can run away or fight. And at the same time, to have all this energy there, it shuts down our immune system, our digestive system, and parts of our brain that we really need to think logically are not available. This is why we have to pay attention to this and teach people and little people who've experienced trauma, and particularly those who've been diagnosed with PTSD, is that this is your body trying to defend. And I always tell my clients that your body is your best friend because it actually has you at number one, in the number one position for priority, and it remembers everything that has ever happened to us. And this is just another diagram to kind of show. So this system was designed to come on for brief moments in those moments of danger, and then designed to shut off. But the problem is when it doesn't shut off. So if you're constantly being activated and you're not safe. So if you think about little people growing up where there's intimate partner violence, they have that persisting mobilization response and whatnot. And then that's where we really get the problems. You know, you look at the ACEs, those adverse childhood experiences of constantly being in threat. So I like to teach this little teaching tool as ways to work with little people, but even adults. So when you look at the fight flight response, if you were to look at my hand, this would be the reptilian part of the brain, the oldest part of the brain where the fight flight response is in. And then when you flip your hand over and cover it, that's the cortex. That's the other thinking parts of your brain. So this part of the brain develops first, and this develops after birth and then through the years and keeps on going, right? So when our brain is like this, we can think and we can look at things that have happened and possibly problem solve or talk to someone. But what happens when we get a perception of immediate danger or threat, and this could be an emotional one, not just a physical one. I'm going to lose a friend, or maybe I'm going to lose my job, or a loss of a relationship. It could be any numerous things, anything that my body perceives as a threat. What can happen is it goes right from here to here. So one of the psychologists I work with, he calls flipping your lid. He works with a lot of youth. And when this happens, really what's working is the oldest part of your brain, the fight flight response. And also that's where food is in there and the procreation, those very strong pushes. So when you're like this, in this state, you actually can't engage and use your brain. Remember I said when the fight flight response is activated fully to fight flight, you can't think clearly. So really it's important to use this tool to help individuals identify when is this starting to come up, because when you actually track the fight flight response, and I've done this with group therapy for men who've been mandated for alternatives to violence to do year-long therapy, and then their sentence is suspended or stayed, is we do what's a video, and we talk about the day when they woke up in the morning, what happened as they go through the day leading up to the event where the violence occurred. And what individuals learned from that process when you're slowing it down was that they were like this all day, they were thinking, and then when they saw something, and this one case I'm thinking of, the man came home from work early, and he came through the front door and he saw boots that were not his. So instantly, if you think about it, this was starting to lift because he said his heart started pounding and he could feel his jaw tighten and his stomach. So one of the things is really, how do I feel when I'm activated? How do I recognize that response? Because if I know that it's starting, then that's my signal that I need to leave the room. I need to count to 10, like all those strategies we talk about. So I just want to say one thing about the pink hand up, is this is actually a new signal that has just come out with the COVID for intimate partner violence, that if a woman actually has her hand up like this, and you see her, it could be FaceTime or some sort of social media, and goes like this, it's a sign that she needs help from violence in the home. But I just put those pictures there just to demonstrate it's an easy tool. We're walking around kind of with a perfect model in our own hands to teach about this fight flight response. Symptoms of trauma, I'm not going to spend a lot of time. We hear a lot about it. It can be anywhere. This is a really great diagram that shows kind of stuck on, stuck off. You can have from the one end, on the other end, we're just kind of stuck off, as you could have depression, chronic fatigue, disassociation, poor digestion, could have somatic pain and just really tired, and depression. On the other side, when they're stuck on, it's that where you can see the hyperactivity, the exaggerated startle reflex, always looking around the room. Is there danger? Am I safe? Just can't relax. You could see hostility, rage. So it's like stuck on or stuck off. Remember at the beginning, I said that gentle wave is where we want to be. But then when something happens and our body is unable to process what's happened, we didn't have support, our body was overwhelmed, this can happen. So really, when we look at trauma where people haven't been supported through it and they haven't found a way to process, if we can understand sometimes what's happened to us and we have someone with us who really deeply cares what we've been through while we're working through this, that can make the world a difference. But when we're not able to do this, it can actually change how we see ourselves and how we see everyone around us. It can impact the decisions we make and certainly all the relationships we have. And as I mentioned, the diseases, we talked about the ACEs. And of course, you can have self-destructive behaviors as well. I do want to talk about post-traumatic growth because it's really important to know that there are many people who actually going through an experience often learn from it in a way how to manage these types of events and are able to actually become, and in many ways it's referred to as growth, and actually stronger than before the event and whatnot. So it is the silver lining in the cloud, which I don't ever talk about when I first see someone in my practice because it's not helpful, it's not therapeutic to talk about the silver lining when people are in tremendous pain. The standard gold approach to therapy predominantly is cognitive behavioral therapy, and it's really looking at the interrelationship and the connectedness of the thoughts, feelings, and actions. And what EMDR and the somatic-based therapies, particularly EMDR, really focuses on the thoughts that we have and those feelings that are associated, and particularly the negative cognitions that that the person identifies with the event. So an example is, if you know people or people in practice, they just say, I'm just not lovable. I don't deserve love. I'm not good enough. Those are some examples of negative cognitions. And that's really what I'm going to talk about now. So as I'm doing this, a personal inventory, we're going to go through some lists of negative and positive self-beliefs. I just want you to note, do you have, just a number of negative beliefs and the positive ones? Because it's important. It's normal to have both, but the key is how predominant, how often does it show up in your life, and how do you feel all the time? Kind of your perception. If you think of Tigger and Eeyore, Tigger is like happy and everything is just great and cool all the time. And Eeyore, it doesn't matter what happens, it's just kind of more that flat affect. So really what we want is that gentle, is the capacity to experience the range of emotions, but not to be stuck up or stuck down as described. If you're looking at these lists of cognitions, I find them, it's really interesting. So there's like responsibility, about safety, control, and responsibility. People, when you're looking at an event that's happened, will often pick 3 of them and say, oh, all these 3 really fit for me. And then the goal is we eventually pick 1 and whatnot. But if you look at down there and you think about individuals you've met in your practice, or maybe family members or people you know, when you think about these types of negative cognitions, these actually impact us, as we talked about. And these negative cognitions, when we're doing EMDR, after you have processed the event, you actually pair the event with bilateral stimulation to the positive side. So for example, say someone chose, I'm permanently damaged. Then the positive cognition would be I can be healthy, I am healthy. That would be example. Or it was my fault, I did the best that I could, is the positive cognition. And how you feel and what is in your thoughts makes a tremendous difference of how you see everyone around you. So when you look at the negative cognitions, often you do see with that some of the mental health conditions that we see in our practice and people talk about that affects our self-esteem, our behavior, can drive addictions and depression. And when people are thinking that way, it can feel pretty foreign for them to be thinking about the positive things. And just more reinforcement is it can manifest in their life, like why bother? Nothing's going to change. some self-destructive behaviors as well. So as I've mentioned, unfortunately, many of these negative cognitions can actually start in childhood. And so it's really important when we talk about adverse childhood experiences, when we look at parenting and those, and even parents who are in every way perfect or try to be perfect, there's still things that can happen. I think of my very first traumatic experience is actually with an animal. And when I took the training, believe it or not, they actually choose to process animal attacks. And I was a little person, I had just started walking, and we lived on a farm, and we had these big turkeys, you know, the gobblers with kind of the big things hanging and all the big feathers. And my aunt actually went and she actually pulled one of the feathers from one of these big turkeys. She was teasing it. And then she ran away, and I was standing there. And then my first memory is this gobbler pecking at my mouth. And I actually have scars under my lip, and I have a scar under my chin. I have a scar on my chest and on my hand from that turkey attack. From an EMDR perspective, that was the first time I learned the world is not a safe place. And really, it was very interesting. After it was processed, when I was taking the training, it actually felt significantly different after that. But that was my first memory. I don't know it's blood, but I see red, and I have incredible pain in my mouth, and I'm having difficulty breathing because of the feathers on my face. So that something like that could happen in a perfectly as healthy as possible family. That is just unintentional. It was something that couldn't be avoided, but that actually could impact the person. So really, coping versus healing. And I always like to talk about the path of healing, because coping is just getting through the day. And coping to me is something that we do in the short term while we're working on the healing. So healing really is about coming to terms with what's happened and how it feels in our body to this day, and learning to actually connect with our body and to truly understand my body's my best friend. Like if something triggers me, that's my body saying, hey, I need some help. This is still really bothering me. So it's really about moving from disconnection to connection. And really, when we're talking about coping, I just wanted to say disassociation is the Cadillac, and that we really have to be very knowledgeable about what it is, what it looks like, and then how to deal with it, and grounding. And I just wanted to say, just from the somatic experiencing training, it just focused on senses, but there are grounding techniques there. So anything you can do to engage the person, like even drinking some water, is you've got actually taste there, and touch and sight if they're looking around, can actually pulls a person the best way into the present. So senses are the quickest way. As I mentioned, triggers are just, it's the body responding to thinking I am in danger, and it's about their perception, and it just sets this whole cascade from the fight flight response. And it can be actually anything. They could see something or smell something or hear something. I just wanted to show you an image. This on the left is a woman who would have been diagnosed with post-traumatic stress disorder, and the red indicates the overactivity. And then this is the same person on the right after 4 sessions of 90-minute EMDR sessions. So you can see the difference in the activation that goes along with the EMDR with the image and whatnot. So really, she's the founder, and she really, the truth is nobody knows for sure exactly the mechanisms behind EMDR. What we do know is it's efficacious, it works. I had my work done over 20 years ago, and I know people have had it done longer than that. And it does change those memories in the sense that it brings in other perspectives. And when we've had those negative experiences as a child, we're also storing it in a child's brain. And a child's brain is different than an adult's brain. First of all, a child's brain isn't finished growing and developing. The frontal lobe is not done actually about 24 years old. And that's the really part that understands logic and consequences and those types of things. And so really EMDR is just looking at issues are unprocessed physiologically that are stored in the body. And so EMDR is really about adaptive information processing. That's what she said she would have called it if she were to rename it now and whatnot. One of the things that is clinically often done when you're actually processing. So there's 8 phases. So the first part, of course, is taking the history and creating these targets that you're going to. And I always start with mom and dad and move to other things with clients. And it could be they could have experienced bullying, a pet could have died. There's any number of things that we wouldn't necessarily think is traumatic, but from an EMDR perspective, there are many things that we overlook, and those are the things that I focus on. And then the phase 2 is really about stabilizing, determining this disassociation, resourcing, inside their body and around them, what's going on in their life. When you get to phase 3 and 4, that's when you're actually using the protocol in the terms of the bilateral stimulation. So you get a picture to them to describe an image. You identify, I have a list of negative beliefs, much like the one I showed you. And then we look at the emotions and then the body sensation. And once, often people say it's a 10 out of 10, it's an 8 out of 10 when you're using subjective units of distress as SUDs. So it's not done being processed until that SUD is a 0 and the VOC is 7, meaning that they believe that positive cognition, such as I can be healthy now, it wasn't my fault. And when you do the scan with the body, with the memory and the positive cognition, they don't get any unusual sensation, tension, or tightness. The body never lies. I've had people who reach a 0 and it's a 7, but the body scan is not clear, and you go back and you continue the process. So when you're looking at the cognitive appraisal, you're looking at the cognitions, and you're also looking at the body sensations. All that has to be clear before it's done. So really, it really seems to have a direct impact. And one of the things that often I'm doing, they're called cognitive interweaves. So we're in the state of processing and someone just still feels responsible and whatnot. So for example, you could have an individual say, perhaps, let's just use sexual abuse because it's actually very common. And the person is 8 or 9 years old, and they feel responsible, like I should have told someone, like I should have done this. And then something in terms of a cognitive interweave or a corrective experience, you can actually say, do you know someone who's 8 or 9 years old right now? And how much power or capacity do you think they would have to actually get away from someone in that situation? And more often than not, they can see, well, no, they couldn't get away from an adult and whatnot. So then there's that not the self-blaming, understanding that, yes, I did everything that I could. So corrective experiences are something I use a fair amount with EMDR, and it actually comes from somatic experiencing. It's going back and doing that inner child work. What would you say to that little 8, 9-year-old? What do you think that little 8-year-old needs to hear to get through this? And sometimes they just say, they go back and they'll say, I love you, you're gonna make it through this, and just whatever the I guess the loving, kind words they need to hear. And they know because it's their little person. This is just a diagram just looking about the trauma, the EMDR, and the adaptive links, the cognitive interweaves that come in, and then the adaptive resolution. I want to talk a little bit about the relationship. As we know, relationship is key. And when someone comes to us, there's that power differential because, we're the doctor and they're the client. And the Partners for Change outcome management system, I've been using that. Unfortunately, here in Saskatchewan, actually everyone used it in adult community mental health. And at first it was kind of scary when it was first brought out because you actually had the client rate you. So this actually goes from 0 to 10, and it's exactly 10 centimeters long. And the client will rate you. So I felt heard, understood, and respected is a 10. And a 0 is I did not feel heard, understood, and respected. So if they rate you anything less than a 9, then the conversation is, you know what, I noticed you, I fell below here, and I would like to know what I could do better to improve this mark. So it really is about actualizing, operationalizing patient-centered care, patient voice, and it's also a way to assess cultural safety, cultural humility, cultural competence, whatever terminology you're using, because this puts the patient voice at the center. Goals and topics. We worked on and talked about what I wanted to work and talk about. Are we addressing what they actually came in to see us for? And they rate. And the approach. Was it a good fit for me? And overall, was the session right for me? I do this with every patient after every session, with the exception now of COVID, is I'm not doing it because of, not touching things. But I have these laminated in my office, and then they just put a mark. I take a ruler out and I score it right in front of them. And then when I see them at first, I want to know, how are they doing? Are they getting better? What's better? And, you know, kind of what's staying perhaps the same and what's really not moving. Here again, this goes from 0 to 10. And I just say, over this past week, where do you think you are kind of overall, your personal, how about your relationships, or how about school and work? And then this is all plotted on a graph. So this is a graph. This is an actual client that I saw in 2018. You can see her overall, her outcome rating scale, the ORS. She scored herself a 6.7, which is very low. And you see the cutoff is 25. So when you're using this type of system and it has it's reliable, it's been tested, you know, so it's an evidence reliable based tool. When typically an individual scores 25, that's the cutoff that they really no longer require to be in therapy, because they're considered to be in a state that they could be fine. What I find is when I do the EMDR, which I primarily do 99.999% of the time, is they move very quickly to 25, but I do not discontinue my work until I've done what we've contracted to do. And they just feel better because things are being lifted. You can see my scores at the top there are just above 35. You don't want to fall below 36 actually is the ideal, and how they go. So this client, I only saw this person 6 times. And then they came back 2 years later because something else had happened. So this person had, their partner had been murdered. And so this was the work that was contracted to do, and they felt fine. They felt so much better. They're able to cope. And I see people for 2 hours. The initial assessment is 1 hour, but when I'm actually doing trauma work, I do 2 hours. And I've done that change after attending trauma workshops. Dr. Ricky Greenwald, he has a trauma center in the States, and he works with a lot of children. And he says you can process far longer than 1 hour, and that it's really about meeting clients where they're at. Some of the key phrases I've heard, you know, afterwards is, I can read now, I can concentrate. That heavy blanket or that heavy fog on my body, like it's lifting, it's going. Somatically, so my heart feels light. Or I had one person who said, my heart was so black. Now it kind of feels like empty. Like, what am I going to do with it? Like, there's not that hardness there in there. So all these types of changes. And some have said to me now, what all other therapists have said to me in the past, I can do it now. You know, I can do those strategies that I tried so hard to do before, but I couldn't do it because those negative thoughts I had were just too powerful. And as I'm closing up here to leave time for questions, I was fortunate. I lived in Tokyo, Japan in the 90s. We had a chance to learn about the Japanese culture and a lot of their healing modalities, some of which I practice now on myself, part of my own balancing. But I really wanted to share with you the kintsugi. It's the Japanese art. And it's really, when pottery has been broken, it's put back together with gold. And I think sometimes when we look at people who've had so much trauma, they can be looked at as less than, and they certainly feel less than when they've been hurt numerous times. And I look at people as incredibly brave, and I'm incredibly humbled when they come to work with me and we work together in my practice, that they are actually willing to go to that place that more of us need to go, and with the proper support. So these beautiful bowls represent just kind of like, we're human, we're not perfect, things happen, and it's about owning who we are and loving who we are. And that's what I feel is one of the greatest gifts, that, you know, having that connection with my culture, about my identity, and understanding that I'm never alone spiritually. Having that just has provided me with the strength more than anything else. But then having these other ways to look at life has also really enriched my life. So I'm just finished up there to give some opportunity for questions and comments. And I see one question there. Actually, yeah, you can do it prenatally. And I actually took some training to do that. And then I went back. I flew out to Vancouver to see the psychologist who did my trauma work, because she did prenatal work. And then she did it on me. So I did my prenatal work with the Emdr. I also did it with somatic experiencing. And absolutely, you can do that. So when you've cleared everything out that the person remembers, and I've done lots of incidents that are pre-verbal, meaning they've happened before the person can talk, so they actually can't tell you about it, but you can actually track the body sensations and you can still process it and release that physiological energy that has remained in the body. So absolutely, yes, you can do it. And it was really interesting when I did my EMDR work with prenatal stuff. So it actually, not to say anything, but my mother had always told me she was really, really happy and excited. And I'm sure she was. But when I went back, I felt the incredible fear she had. And actually, it created more compassion for me to know that must have been really scary for her when she was pregnant with me after everything she'd been through. And I was her first child. So it was just that connection, that greater compassion. Would I recommend training for EMDR? I took my training in BC and in Calgary, and I know that there's different trainers. What I would say is the training is pretty standard. It's probably afterwards I've sought consultation with people, and I'm trying to think of his name. He's just fabulous in BC, but he's one of the EMDR consultants, and he's been working, he's non-Indigenous, working with First Nation communities like for 20 years. And if I think of it, I'll send it and whatnot. It's so standardized, the training for EMDR, because it's a protocol, it's a book, it's a page that you follow. You really can't go from there, steer too wrong from there. I think there's a lot more supports taught. I had EMDR under the old protocol as a client. Then when I took the training, I took it under the new protocol. And the new protocol has a lot more of supports to assist people to go back. It's integrated a lot of the SEs, the somatic experiencing, I don't want to say props, but supports to go back into trauma and whatnot. So yeah. Any other questions?
So I don't know if that was your answer, but someone else was asking, where would you recommend training for EMDR that may not only be out west?
Well, actually, the one who comes to do training here is from Ontario. Sue Genist. She's done a lot of training, and I've taken a refresher course from her. And then I took one from Dr. Arnold Popke. He had a EMDR protocol for addictions. And so she was there and in that training as well. So I know that she does a lot of training, and she does a lot of that supportive work in terms of assisting people to go there. Like one of the things with EMDR, when you're having someone to go back to the traumas, you don't want them feeling like it's happening to them. You want them to watch it like a movie. So I have a little stuffy lion in my office that a lot of people love. Or you could take Mary Poppins with you or someone. I don't recommend you take a family member because they're going to see everything that happened to you. So she's really good at teaching that. And she has lots of additional supplies and in terms of resources and references that she puts on her website and whatnot. So she's from Ontario.
Great. And I have a question that's not in the chat, but that I was wondering about. And what are some of the challenges of EMDR with Indigenous people, do you think?
Well, I think the challenge is, first of all, knowing that it even exists. I think is most people aren't even really aware of EMDR or how it works, and there's not a lot of practitioners. So I think access is a huge issue. For the Indigenous peoples I've worked with, they've been absolutely wonderful. I mean, once they've experienced one session, and you feel the difference in one session, so it's not something where you have to do it several times. You feel the shifts in the moment when you're doing it. And when they feel those shifts and feel things changing in their body, they come back. So I've never had an issue with someone starting and not wanting to come back. They're always eager to come back. I think when you look at any engagement, it's always about trust versus mistrust in terms of history. So I'm very transparent. I do, before I meet with them, I get them to look about information EMDR. I'll send them, information so they can have all their questions ready when they see me, and I can answer them all. For me, it's about educating, letting people know. EMDR is not about erasing your mind. You know, I do a lot of the teaching of what it is. It's about allowing your body and your mind to actually process what happened to you. And you will always remember what happened to you, but you won't think I'm unlovable. You won't think that I'm damaged. And you won't have that feeling in the pit of your stomach when you think about it. That's what EMDR removes. And that's what's so powerful about it. But it doesn't erase the memory. So it doesn't erase who you are as a person or what you've been through and whatnot.
So I was just wondering more because, you know, there are so few Indigenous practitioners across Canada. And I think going to someone like you would be amazing experience, whatever modality and intervention you were using. And I think there's no doubt about that. But I'm just wondering, like, what the likelihood of anyone who's on this call or just sort of any Indigenous person in community, if they were to find someone who practices MDR to work with, and they weren't Indigenous, what would be some of the sort of things to sort of be aware of or be concerned about? Because I think, you know, from my clinical experiences of working with Indigenous people for so long, is it's kind of goes down to what you said about that lack of trust, but for a good reason, because often Indigenous people do have very negative, adversarial, or even harmful experiences when they see non-Indigenous practitioners, especially from my experience in psychology.
Mm-hmm.
That there's always that risk that there's going to be harm done rather than healing. So I'm just wondering how we can address that with people who are looking for someone that can practice EMDR.
Well, you know, Suzanne, the best is word of mouth. For me, I've had clients who've posted on Facebook here in Saskatchewan. So I get everyone saying, you know, I checked Facebook and and I'm good. And I think that because my mom was in the residential school, I've grown up on and off reserve, like I understand, like, you know, a fair amount of it. And people know that when they talk to me, right? I refer to one other person because she was my supervisor for working with children when I did the licensing. And she took EMDR training after we met. And I know that she won't, like, she doesn't harm, like she will not harm anyone. So I only do referrals to people that I've worked directly with, because I wouldn't want to be responsible if they didn't have that experience. But what I tell clients is if you don't feel heard and you don't feel safe, it's like finding a hairdresser. Find another psychologist, another therapist. And if you're not improving and you're not getting better, then find someone else, you know, because it's all about personality too, right? It's like, it's a very intimate fit, so to speak, when we're talking about personal things that have happened to us. I'm hoping that we'll have more Indigenous peoples who are actually trained to do this. And one of the limiting things is you have to have a minimum of a master's training to be trained with EMDR. So for many social workers who would probably be fantastic at this, they couldn't take the training and whatnot unless they did a master's. So the level of education required is certainly a barrier. But I do think that the more we talk about it, and if people experience it, then we just get more people who are available to provide this.
Great. And one more question is, so if someone wants to go see an EMDR therapist, who pays for it and how much does it cost?
If non-insured health benefits actually covers it if you're treaty. So if you're treaty, then, and even if for missing and murdered Indigenous women, like they have coverage for that, a residential school, they'll cover it. So if you have someone who's coming in who's suicidal and it's related to past trauma, I mean, that's where it is. So I always address it with that. So that's where that would come. I'm just looking up Sue Genest. So Sue Genest is S-U-E, Genest is G-E-N-E-S-T. That's how you spell her name. And if you just Google her, you would see it, and it just Sue Genest. It just comes up, EMDR basic training. And yeah, I hear you, the anonymous person saying I have 2 bachelor degrees, and I'm not sure what an RP is, but yes, they haven't changed it. and they have not made any exceptions to that. Because when you're doing EMDR, as I said, you're working with a different part of the brain, and it's different than talk therapy. And so that's the thing with somatic-based therapies, is you're working with different parts of the brain and whatnot. So they have not talked about anything. I've asked about that, and then they're not willing. Every time I've engaged, they're not changing that requirement to have a master's. So thank you for bringing that up.
Thank you, Dr. Graham. I'm going to turn it over to Clay for concluding comments and spiritual closing. And before I do that, I'd like to thank you, Dr. Graham. You're so amazing and inspiring and wonderful. And it's been really thrilling hearing your presentation, and also hearing all the excitement and the interest from the participants. And this is really cutting edge and another tool we can use to help manage some of the things that we're dealing with right now. So Masi Cho, thank you, Dr. Graham. And Clay?
Well, yes, it was just fascinating, Dr. Graham. I've never really heard much about it and everything, and it just got me thinking about how do I, like this, as I loved what you said about, if that person's not the fit, try something else. And that's what I tell other people when they go see a spiritual leader or a healer. I say the same thing to them. Go and see, if you don't like that guy or that person, try that one, and try and tell that one that fit and tell it everything. And I really appreciate that comment, because so many of us, like you were saying, we're trying to heal ourselves and support each other, and we're healing, we're on this journey called our lives, and we're all healing ourselves from the traumas of colonialism, etc., and racism and sexism. We're all doing this, and so many of us are stuck. And so I noticed in the past, when they want this help, they go to one healer and they say, well, I have to stick with this healer and everything, and it's not a good, but it's not a good fit. And I really appreciate that when you just say, yeah, that one maybe not, but try this one, try that one. It's up to you. And it's such a very important comment, because it's so many of us as they're learning to speak up and to say, this is what I want. I want a good life. I want to take that medicine with that healer is providing, that ceremony. And this is just one more thing. And this is why I say to them, just explore it all. And I love what you said when you said go to, you study in Japan in Eastern philosophy and Eastern medicine. Same thing for me. I've never been to Japan, but I was planning on going there, but then COVID happened. But anyways, but it's just, so thank you for that. It got me thinking about all our medicines and our healers, and one more for the healers to talk to, because that's what I say, because saying to them, look, you can go to here and you can also use both, right? Go in there, go get, what they say, diagnosed, if you're a terminal illness, etc., and then approach it to that healer, right? It makes the job for the healer actually a lot easier. I've noticed that if it's physically, mentally, spiritually, emotionally, it doesn't matter, because it's like, so the combination, and I just encourage people to do that, and that's what I think I'm hearing here today. So again, miigwech for that. Yeah. So with that, we'll take a moment or two, and I will just say a closing. I just want to say miigwech. I give thanks again. We give thanks to our Creator for today. Say miigwech. We give thanks to Father Sky, Grandfather Sun, Grandma Moon, everything in between Earth and Sky, our four-legged friends, the crawlers, the swimmers, the flyers, in gratitude. And we give thanks to our Mother, the Earth. We ask the spirits of our ancestors to guide us in this very difficult, challenging times, to protect us, to protect our children, to protect our loved ones. We say miigwech to our ancestors. We thank them from our hearts. We offer our tobacco and prayer. We offer the medicine. We ask them that guide us in this difficult, challenging times. And I asked grandmothers and grandfathers to bless our healers, our medicine people who are working so hard for the people. And I say miigwech to you, Creator, all my relations. Miigwech. Thank you, guys. Dr. Graham, thank you.
Miigwech, thank you very much. And thank you to all the attendees as well. And just a reminder that this webinar will be posted on the Ontario NEIHR website, which you can find just by typing Ontario NEIHR into Google. And thank you very much. Thank you again, Dr. Graham. Thank you, Clayton. Thank you to all the participants. And we'll see you next time for our next monthly webinar, which will be in April. Miigwech.
Miigwech.
Which